CIT certified. I met these fine folk at the 40-hour-a-week training that we all completed that covers a grand scheme of things, a lot of mental health, substance use, any developmental disabilities. We were talking earlier, it's a variety of people that come in, professionals, also clients, people that have been served, and what's going to work best for an approach for them when they're in crisis. So from that, we've built this partnership. Gateway covers the mental health side, mental health and substance use, so anybody that is struggling with a crisis situation or family members that are worried about a loved one, friends, neighbors, they can call the department, and together we go out. The officers will respond first, make sure the scene is safe, and how it's been working is they'll give us a call and we'll either discuss the case and maybe we don't need to respond, but we're available to respond on scene to help complete an assessment. We were trained in the hospital to do the same assessment that they received when they come in, so we can complete a lot of that paperwork and the timeline, and also determine if somebody actually really needs to go to the hospital, or maybe they would be better served by getting some resources in place, so we can kind of cut down the revolving door that we see within our ER departments as well. And we are also able to kind of look and see very specifically the needs of a person. So sometimes a crisis will look like, as they were saying, they'll get a call and it sounds like one thing, but maybe it turns into something else. So our training has provided us the ability and the resources to really look at what might be going on with a person and make sure that they are connected to the resources that they need. Part of the follow-up piece, which I think is incredibly important, because sometimes people will go to the hospital and they'll get discharged, but they don't necessarily have that follow-through with a follow-up piece. And maybe they don't know how to ask questions, or they are going along with what they were informed to do, but it's different when you kind of get back home and get back into your own environment. So we go out on our outreach and we can talk to the families, we can talk to the people, we can see what they need. Are they getting what they need? Is it working? Do they have questions? Some of the examples that we've had is responding to a home after somebody has gotten out of the hospital and they're on new medication. So some psychoeducation that might go around that, or helping the family determine, is this what you were looking for? Did you get what you needed? Is there more questions? There's a lot of questions about HIPAA, and I'm really still worried about my loved one. Can I call the doctor and let them know this, or I know they can't give me information, so we can help them kind of sort through the psychoeducation piece, but also really ensure that a person is getting back on track and stabilized, and the resources they need to help them, because I think as a collective we've all been struggling. So this is really an approach to say it's okay to not be okay. It's okay to kind of be struggling. Here we can help before it gets to a place where it's hard to return back from. So we're here to support you.
Mary Kate, I have questions.
Of course.
One word or two, Mary Kate?
One word, capital K.
And McCarty?
Yes.
Spell it for me.
Sure, it's M-A-C, capital H-A-R-D-Y.
Capital McCarty.
Yes.
M-A-C, capital H-A-R-T-Y.
D-Y.
D-Y.
Yeah.
Are you a social worker?
My background is I have a master's in forensic mental health,
Okay.
forensic psychology.
So you've gone on these calls?
Yes. So part of what we also, aside from our CIT qualifications, we are also qualified mental health professionals from the state, which allows us the ability to go in on these calls and kind of make that determination. We do have the ability to do an emergency certification if somebody isn't willing to go to the hospital. 'Cause that's always the first goal, is to kind of encourage somebody to go on their own. If they're not able to, if they're not at a place in their headspace that they can make a good decision for themselves, we do have the ability through the state authority to certify somebody and have them go be seen by a doctor.
You've been out on some of these calls?
Yes, I've been doing this, was hired in 2019 for this position.
So any instances that strike you as unusual, or
think we can all agree that if you're in a crisis position where, you know, the officers are being called to respond, it's an unusual position.
Sure.
So they're not, you know, not in good spaces at that point. I don't want to give any specific
No, no,
cases.
you don't have to. I'm just asking in a general sense. Do you have any that strike your memory as unusual?
Certainly. I guess that's why it's so great to have a partnership rather than, you know, as they were saying, some departments and some states are looking at models where the clinician is responding to the home, you know, maybe with EMT or something, but having police there because safety is a concern. Generally, when we're responding, the person's not in the right state of mind, and there's, you know, we don't know what we're walking into at any given time. So,
Any particular success stories?
I would say so. Well, so as the captain was speaking about, we've gone on these outreach calls in the last 2 months, and there's a lot of people that may be chronically having trouble or kind of coming back to the officers or chronically responding to a home. We have been able to get people into services. We have been able to set people up with something, and we haven't heard their phone calls coming back in. We haven't really had to respond too much. We can continue that follow-up, so yes.
And you've been doing this since 2019. Is this in conjunction with it? Because they've been doing it for 2 months. I mean, were you doing it with the Cranston Police or elsewhere, or?
Sure. Our program has been funded by the SOAR grant, which is the statewide opioid response. So we've been embedded in local police departments. Our relationship started when we were all at the same CIT trainings, happened to be sitting next to each other, and realized that we can kind of build something together. Because as the local mental health department for this area, we are their go-to emergency call services. So we do have a 24-hour line that anybody can call Gateway specifically and request emergency services.
And what is Gateway?
Gateway is the community mental health center that covers the Cranston region.
Is it affiliated with one of the hospital groups, or?
It's in a lifespan affiliate.
Lifespan.
Yeah.
Thank you.
So in this experience, right, so you had this experience working in this capacity prior to the beginning of this program, where you guys are talking about seeing some success. So let's just try to get a sense. What does that success feel like to you? So, you know, you had the experience previously over a period of time where I take it there were more repeat calls. How was your own time and your own effectiveness? Can you quantify improvement? I mean, do you feel that your own work is changed now because of this program? Are there any ways you can quantify that? You know, like I'm able to spend more time doing X now, whereas before I was spending so much time doing Y that I wasn't doing as much time with X. Any little things you can say right out of the bat, you know, after this 2 months like this, where you can, you know, so that we know about the repeat calls, but.
Sure. I think a great way to look at this is a proactive approach. So rather than the way that we have seen people when we do crisis work, and from my personal experience, I've worked in the prison, I've worked in the courthouses. So I've seen the reactive side of the system where we have to, you know, they've already been charged with a crime, but we can go back and see that it was mental health related. So now we can kind of come back and look at, all right, well, perhaps this person may have escalated to that point, but then I'm going to pass this to my director because she can say this better.
Sorry, I'm like, poor thing, I should help her. Hi, I'm Elizabeth James. I'm the program manager for emergency services.
Didn't catch that. You're who?
Elizabeth James.
Just like it sounds?
Just like it sounds, just like from Parent
Program
Trap.
director with Gateway?
With Gateway Healthcare, yes, for emergency services.
Uh-huh.
So, like Mary Kate has been saying, we have been with the local mental health center for the city of Cranston, along with several police departments, including down in South County as well. A lot of people don't know Gateways in South County, but we're part of that as well. So before we joined with Cranston, We have been working closely with Westerly, North Providence, and Smithfield Police Departments and have several success stories with that. And overall, people who do crisis work in general and pair up with the police, it changes you as a clinician, as Mary Kate can say. We see people at their worst, but we also get to see them when they're at their best or doing much better. And that comes through the partnership that we have with the police and with like CCAP and other agencies, because it's a team effort to make somebody better. So we do see a lot of that. And there has been a lot of success throughout. Like, there's things that we do behind the scenes that people don't realize. Like, not in the city of Cranston, because this goes back to the beginning of our program. Westerly had that shooting a few years ago. We were on scene 24 hours a day, not for the police and also for the residents there. We can show up any time of day. We have clinicians who are mobile 24 hours a day. Some of us live in Cranston, and we can respond immediately within like a 5-minute time frame. So that's the benefit of having a mobile crisis team 24 hours a day, because crisis, you never know when they're going to happen. It can happen 9 o'clock in the morning, it can happen 1 o'clock, it can happen on Christmas morning, it can happen on your regular Sunday afternoon. So it is beneficial to have this relationship and us.
And how do you quantify success?
I quantify it as how many people have took the extreme to end their life before, like, what's that number look like? It's been decreased. Like, so we look at how many people complete a suicide. Like, are they calling out? Are they reaching before they get to that point? Are they ending up in prison because of their mental health? Are they getting arrested? Are we helping before then? Are they homeless? Are they not getting their needs met? That's where we connect with other agencies. So to try to get the person to a better spot before they go over the edge.
Thank you.
You're welcome. Okay.
So, did you have mobile crisis interventionists prior, 4 months ago?
I've been with Gateway for 21 years,
Yeah.
and I've been an ES clinician that's been mobile for 21 years with Gateway.
Okay, so but what's new here is that in the Cranston area, there's a certain coordination with
Correct.
the police department. It's a higher level of coordination
Correct.
than what you guys did when
So
you
we are actually
previously.
going out, and we're actually being, like Mary Kate said, we're being more proactive. We're not waiting for the crisis to happen. We're trying to prevent it before it does happen.
Yep.
That's the key.
And so what you're seeing is that in your centers, as a result of this new type of activity, you're seeing fewer patients maybe getting admitted. You're seeing fewer situations where people end up in extreme scenarios where they're arrested than maybe previously.
We are seeing a reduction in that. We're also part of this, like Mary Kate had mentioned too, is to help avoid people unnecessarily going to an emergency room. If they don't need to be in an emergency room, then we have the same capability as the clinicians, because they're Gateway clinicians over at Lifespan.
But was that reducing the use of the emergency room, was that taking place as a result of your clinicians even prior to this new program in Cranston?
That's hard to say, but it's definitely, with this program in Cranston, has definitely decreased in certain areas, yes.
And that's cost effective, obviously, right?
Yes.
Because the hospital care is a lot more expensive.
It is, and also it's better patient care for the client. So if they don't need to wait in an emergency for 12 or 13 hours or sit there for 4 or 5 days, it's better for them. Their treatment looks different, and we can follow up. Like if we can see somebody on a Saturday, we can outreach them again on Monday. We have that availability. We can bring them into the center or refer them to another center, whatever is more appropriate for them to get them treatment. So the follow-up, like Mary Kate was saying, and the captain, is the key. That's absolutely the key to helping people maintain their mental health.
I think CCAP is going to come.
Yes, CCAP is nice.
We have nothing to say.
Covered it all.
I'm going to do a song. Hi, everyone. I'm Joanne McGonigal. I'm the CEO of Comprehensive Community Action, and it's just wonderful to be here. I just wanted to give a little historic perspective. Since we opened our doors in 1965, we've had a great relationship with not just the City of Cranston, but Cranston Police. We always say that police officers in Cranston are social workers in uniform, and they really are. They've always been 100% supportive of any service that we provide, and we do provide over 70 services within the city of Cranston. We're the largest human service agency here. But we have a history with the police in intervening in mental health issues. Back in the 1980s, we joined with the Cranston Police Department to open up the first youth center in the city at the Pastore Center, because the kids at Cranston East had a suicide pact, and it was getting out of hand, and we joined forces with the police to open that youth center, and the police and CCAP staffed that and provided all sorts of activities for these kids, and were able to really provide some strong interventions to deter them from that action. CCAP measures success in a little different way. Because of our interventions with this program, we really look at how many people are accessing our services. So when you look at the social determinants of health around these families, there are a lot of different points of intervention for them. It's not just that critical mental health crisis. So if people are coming into our system for the food, the housing, for behavioral health counseling, for health care, for child care, whatever that may be, that's a sign of success for us, because we've actually reached that family and begin to address all of those determinants with them. Go ahead, I'll take questions.
It's a matter of referrals from what they find referring them to
Well,
you.
our clinician also goes out too, and then feeds those referrals into the agency. And certainly if we don't provide those services, we'll find an agency that does. Our substance abuse task force is we think it's an arm of the police department, the way that these guys intervene with the police and work very, very closely with the police department. And that's a very, very strong sign of success. But I gotta say, you know, this program really is an example of the vision and the leadership that we enjoy here in the city, and we're just very proud to be part of that. So I want to introduce our worker in the program, Caitlin Bianco.
We're going to ask you to spell your name.
Me?
Yeah.
Caitlin, it's K-A-T-E-L-Y-N. Bianco, B-I-A-N-C-O. No problem.
So what is it you do?
I work for CCAP in the capacity for the Cranston Substance Abuse Task Force, but we were approached for this, and that's just my daytime role with CCAP, so I've been going out on follow-ups with the CIT program as representative for CCAP. So since this has begun in February, we've been able to go out to more than 20 residents of Cranston for outreaches. Through the outreaches, we've connected with them, and I've actually referred to CCAP services over 30 times and 30 different referrals for these families in the capacity of our food bank, our health center, and our general outpatient counseling as well. The one that stands out to me the most, though, that I think is the first success we really had was from the very first week that I actually was able to go out with the officers. We had an 8-year-old that had an incident at school, and he was actually taken to Hasbro Hospital that day. An officer and I had gone out to see if the family just happened to be home at that time, and luckily they were. Mom was new to navigating the whole system, and she was very overwhelmed by everything that was going on. So what I did was I gave her CCAP's basic information, and then I left my card and said, if you need anything, please reach out. 2 weeks later, she did, which to me is a success, because if they remembered me and they remembered what I did and they called, that's huge for us. She said that the hospital had given them a therapist, but her son just wasn't connecting with that therapist very well, and so she wanted some more help. From that, I got her into 2 different case management type programs and clinical help for her son. Mom had stated to me that she was so grateful this was around, because help came to her rather than having to go search for it herself and not knowing the system. She wasn't sure where to start. And she's very, very excited with all the services that have been placed, and she's already seen a change in her son in this short amount of time that it's been happening. So that's our main success story.
But you've made 30 referrals in 2 months. It's one every other day, and that's just you?
Yep,
Gotcha.
so far.
There must be a certain amount of satisfaction.
It's nice being able to get out there and help the residents of Cranston. You always want to help more, and in other roles that I've had at CCAP in the past, I've been able to do that more, so being able to go back out and do it again is lovely. I do like seeing them get into CCAP. Even as simple as I had a kid who, it wasn't even the primary child that we went out to see, and the daughter was like, I'm just so bored, I need more help. And I mentioned our Learn to Earn Center, and she's 14, and she's old enough to be able to start like a work placement and get towards like a job that she might want in the future. So even like as simple as little things like that, it's nice.
How long have you been doing this kind of work?
I have been at CCAP for 7 years.
Doing this kind of work?
Yes, in many different capacities. I used to do youth diversionary. I live in Situate now, but I've been working in Cranston for 7 years.
Sure.
So I used to do youth diversionary, and then work with clients of Cranston, or people in Cranston who were receiving cash assistance, and then I moved over to the Cranston Substance Abuse Task Force about 4 years ago. So
So this is a type of community impact that is new for you over the past 2 months.
yes,
Right?
yes.
And so those 30 cases that you mentioned, if you weren't assigned to this, if this program wasn't in place, you would have been doing your work with the Substance Abuse Task Force, and those 30 cases, we don't know what would have happened in those cases.
Yep.
There wasn't somebody on the job doing that particular type of work in this way before this program, right?
Correct, yeah. I mean, we have people out there, we have our case management programs, and we're always kind of talking up what CCAP has to offer, but if we didn't have the ability to actually go out with a police officer after a mental health crisis, these people might not have ever come through the doors of CCAP to get the services, to get the food, to get the health center services, to get dental at the very least. So it's been great. Thank you.
Like I mentioned, we have two of our CIT officers here, Officer Harden and Officer Alfonso. Officer Alfonso is going to give a quick success story, if you will. I know that you're looking for one. Yeah, we don't talk about any failures, only success.
My name is Officer Joe Alfonso. I've been here at Cranston. Alfonso, A-F-O-N-S-O. I've been here at the police department for the past 11 years. I kind of caught on to the whole mental health aspect of this a few years ago. I became an instructor with the mental health first aid. I went to that school back in 2018. I did all the in-services here at the department. I went to other police departments, did training with them. Went to the Municipal Police Academy. Did training with all the new recruits. And as time went on, I kind of saw a need for this. As I was teaching, as you follow suicide in law enforcement, suicide in the general public, the numbers just keep going up. And as working in patrol division, where I've been working for the last 11 years, you just see the only avenue that we really had through the amount of calls for service that we had was just calling for a rescue and having them sent to the hospital. And it wasn't working. So through just one day with conversation with Captain Dutra, we just try to start a program with the blessing of the Colonel, and this whole program started off. And without, the guidance of the clinicians who actually, do this for a living and kind of helping us set this up, it's been working very well. So that's one of the biggest things that I've seen here is one of the stories the Colonel I mentioned. I'm a veteran, so my passion for mental health goes back to 22 suicides a day, veterans. So I've always had a passion for this due to that. There was a call for service for a veteran who abused substance, alcohol mostly. It was a repeat call. We always dealt with this individual, and we got a call that he possibly was angry under the substance of alcohol, and when we got there, he had left the house. So after walking the neighborhood and looking for him, I ended up finding him, kind of made a connection with him. He was trying to avoid me, but once we made that connection, he was very standoffish at first, but sitting there talking to someone who was a veteran, and we, seen the same things, dealt with the same things, he became receptive to it, and then he was open to getting help. That was probably a year ago, and we have not gone or had any dealings with him since then. He went to the VA that day, and I haven't heard from him any negative from him since then. So
I think you drove him to the
yeah,
VA hospital.
so that's another thing. A lot of people don't like to go on rescues. They don't like the noise, the lights, and all that. So through the department, with that instance, drove him to the VA. We also partner with, we have a connection with BH Link in East Providence. So a lot of times when we go out for these calls, sometimes they just want to sit in the car with you. We just drive them there. And it's a lot better than going to the hospital, lights and sirens. It just, it makes the person feel more comfortable getting help instead of putting on a big show.
That was a type of success that stood out
Yes.
from having those experiences where you felt like you weren't succeeding, right?
It was just, yes, I mean, you just see it every day. We go to the same, in this position, I go back and I look at different call numbers and different addresses, and you just see the same address and the same call always coming up, and nothing was getting done. Because, again, services are limited, it's not, and we all know, like, mental health services have cut down over the years, so a lot of people don't have avenues to go to. So now with partnering with all these agencies, we're able to actually look at these calls, read the narratives, see what's going on, and actually pick kind of what agency would best suit them, and that's worked.
And so the approach that you took in the case of the veteran that you
Yes.
just described was a little different from other situations in the past.
Yes.
And you feel that approach led to that success.
Yes, you always try to,
Whereas maybe
yeah.
if you hadn't taken that approach, you might have had possibly, another situation that was a lot like the others.
Yeah, you got to feel every situation. At first, I try to talk to him. Then, as I felt he wasn't receptive, then I try to find some, common ground with him. And that's what it was. And we try to do that with everything. And the biggest part of this that I think it works too is people are very intimidated sometimes of the uniform. So that's why the colonel approved these softer uniforms. So it makes it so we're going there and it's not this authoritative appearance, and people feel more comfortable talking to us. And I've gone out with them, and they're like, they've gone out with officers before, then they come with us, and they always say, why do you have to bring the police? Well, I'm not really here as a police capacity. I'm just here to offer services with them.
What military service did you?
Marine Corps.
You mentioned the softer uniforms. Do you go in a traditional police car, or is it unmarked?
It's an unmarked car. So it's unmarked. Until I get out of the car, you can see, the belt. It just looks like we're just a normal group of people going to a house.
Colonel, I have a couple of questions for you.
Sure.
What's your total complement?
Well, 153 when we're fully staffed, and we're at 147 right now.
And so 8 officers. Well, you said you started out saying the whole department has had a level of training
Yes.
in mental health. Is that typical in most departments?
It's actually
now?
required by law. Mental health first aid, they passed that law a few years ago. Some departments are still working their way through it because there's no time frame put on it, but we jumped on it right away, and we have several instructors that actually train other departments and as well as our officers.
So 8 out of the 140 some odd. I mean, that's a pretty good number. I mean, it's a start.
We're looking forward to doubling that by the end of next month. In the CIT model, I believe they recommend 10% of your patrol division should be trained as CIT officers. These officers, just to be clear, they're regular patrol officers. If a call comes in,
Yeah.
right, our dispatchers, if they hear a call that is clearly mental health, they're going to divert one of these officers to that call because of their additional training. It's not always possible, but they're definitely going to be in the follow-up aspect of it.
So they might be in uniform and then they change into these uniforms?
Yeah, 3 times a week they go out on their days off, in these uniforms and do the follow-up. So it's in addition to their regular patrol duties.
And are you aware of other departments that are involved in this kind of training? Maybe some of the clinical people know. Are there other departments involved in this kind of more intensive approach?
I know Narragansett, because I happen to be on the Police Chiefs Association with Chief Corrigan, but they may be able to speak to other departments. I'm not really sure. But I know CIT is not, it's spreading throughout the state, I believe.
You guys have something special going on.
We do. Well, I'd like to say we're special.
I mean,
Yeah,
we're,
something special.
oh, and the funding for this, you mentioned a CARES grant in
Yes.
2020. How much was that, and where do you stand with that?
How much money was roughly?
I think we're allocated just under $40,000 for a year's worth of services for the officers. That's 12 hours a week for the follow-up visits.
For training?
Training and
No.
overtime. Because they're on their days off, because there's no way they can do it during the regular shift because of the volume of calls.
Really?
They won't be able to spend the time necessary with these people.
40,000, what, came in 2020, or?
It was allocated to the city in 2020 through that CARES grant. And then we applied to the city for funds through that grant. It was obviously a lot more money than that in the grant, but they cut out this piece to fund this
40,000.
program.
And that was a one-time thing, or is this been
Well,
recurring, or?
it's a one-time thing. We report quarterly. Actually, tomorrow, I have to report the stats to the grant manager here in the city for the program, and quarterly, we will report that.
We're 3 fiscal years down the road now, so, I mean, has this been coming at you for 3 years, or just a one time?
Just the one time right now, but we have the ability to apply again. I believe that money has like 2 or 3 years to be fully expended. So we could apply again, but really hoping that Senator Whitehouse's bill would, that's pending right now, we just introduced, would carve out money and fund these programs throughout the country.
So just to simplify, the officers are on their shifts, they're in their uniform just
Yes.
like yours.
Mhm.
They apply their skills during the course of their shift
Yes.
with their uniforms on,
Mhm.
and they're not earning overtime. Then, as a result of this program, they do follow-up where they put on their special uniforms, they earn overtime.
Yes.
And that overtime is funded by the $40,000 that you just mentioned.
Correct.
3 times a week?
3 times a week right now because of the volume. But I can tell you that it might not even be the same officer that responded to the original call, because there's going to be 16 eventually, but with only 8 in the number of calls, they may have not been the officer on scene for the initial call.
And we also scan our calls for service on a daily basis. We have a lieutenant down in the patrol division who happens to be crisis intervention trained. So he'll come in the morning and he'll scan through the police reports that were generated the night before, and he'll read the narratives. If he picks one out that he feels could use a follow-up by one of these officers, he'll then assign that too. So that way, nobody falls through the cracks. Prior to this program being organized like this and having somebody filter the reports on a daily basis, reassigning them, you could very easily have an officer respond to a call, identify, what is potentially a quality of life, a mental health crisis, call a rescue, clear the call, and, not really initiate any follow-up. This is where we head that off. Very specific. So we're trying to grab every single call for service that comes in that is going to fit these parameters and then address those issues accordingly. So I think that's where this becomes very, very unique, especially with the clinicians. Otherwise, they're just waiting for people to come to them. Now they have access to those 80,000 calls for service.
Did you say at the outset how many calls in the last 2 months got funneled into this?
So we've generated, since February 7th till today was March 30th, a little less than 2 months. Today's numbers, a few days ago, it was 100 of these police reports we've reclassified and generated through this process, and they've done over 50, 60.
Up to 60 outreaches.
So what we'll do is the officer will go through these calls for service, the lieutenant downstairs in the patrol division. He'll reassign the case, and then we'll put a package together that will have the particulars of the incident, how we were called. We do a little threat assessment for safety. We don't want to go out to a call for service that maybe there was some sort of violent interaction the night before with the police. We don't want to flare up an incident that has calmed down. We'll seek alternative ways to outreach those people. If somebody's is wanted or something like that, we shy away from that, and because we don't want to send these officers out there to offer assistance, and now we're engaged in an arrest or something to that matter. So we're trying to keep this separate from traditional law enforcement duties. Yep.
What's it going to take for you to expand? More federal funding, you think?
Well, the training itself is free, so that's the good news. If the volume of calls continues to increase, then that will increase the number of officers that will have to go out off duty, if you will, on their days off. So we're going to have to monitor it. But I think we can get more money if needed. We just figured that was the approximate number based on the calls, but what we're seeing is this program's taken off pretty quickly. So hopefully, whether it be federal, state, or local funding to make this continue.
But just to balance out what Justin just said, you're not trying to inflame the situation, or aggravate it. However, the ability to have a police officer go to a particular location where there's been some trouble, the presence of a police officer enhances the safety for people with the clinical skills they have, and so they might be able to sort of do more outreach, get to those locations sooner after some strife, have impacts sooner than they might otherwise. And that part of that comes from the officers
Being present.
ability to be there and do police things if those are needed. Right?
As a police department, we're sensitive to it. Many years ago, we had a homicide that happened here in Cranston where 2 clinicians went to a house for an individual that wasn't taking his medication. He lived with his mother at the time. He was an adult, and he had a knife under the seat cushion, and he ended up stabbing one of the clinicians to death in the head, and the other clinician ran out, called 911, and actually Captain Dutra was involved in the arrest of that individual, who was found not to be competent for trial, and he's still incarcerated at the IMH. His last name is Tavares. You might be familiar with the case, but yeah. So that's an example of an unpredictable situation that went bad.
So, just out of curiosity, how has the CIT model benefited the police department specifically? I know that nationwide there have been some departments that said there was an issue with, I guess, having enough jail cells for people because there were a lot of people with mental illnesses who were inside of the cells when they should have been in hospitals at the time. Is that something that this police department ever had to face or deal with?
Well, if somebody's just experiencing mental illness or crisis, we're not going to put them in a cell. We're not going to arrest them or charge them. We're going to get them to a hospital, or we're going to have the clinicians help us. So that really hasn't happened, but it's benefited our officers. They're using less force, which is important. You always hear that when officers arrive, there's a myth that we escalate situations where we actually try to de-escalate, and we do that formally, but we've always been in the business of de-escalation. So it's, and the less repeat calls for service.
Yeah, and so just to make sure I got this right, at the end of this month, there will be 16 officers?
Yep, at the end of April, there's a training coming up, and we're sending 8 additional officers.
Perfect. And so, just having asked this, so the introduction and even like the idea of the CIT model, is it at all tied to some of the, I guess, nationwide calls a couple of years back to having social workers go out on cases instead of police officers from like communities of color? Is that at all tied to any of this, or is this solely just like mental health services and like the escalation of violence over the pandemic?
Well, we know we wanted to do better. We wanted to get more training, and this is just the next step in that process. I can't say it was as a result of issues we had here in Cranston, but we do always look at the background nationally, and so it did prompt us to really focus on how can we do better as a police department, and I think this is a great step in that direction.
Yeah, and so talking to the community, everyone who's going to watch and see this tonight, what is the big takeaway? What do you want them to draw away from the CIT model?
Biggest thing I think is that we're here to help you, not to be fearful, that we're not always there to make an arrest. I think we mentioned only 2% of the time we're there to arrest. If we can assist you and we can work with our partners to get you some help, we're going to do everything in our power to do that.